And for the third case, which is showing how to print the agitated flexion, but I will show the 3-minute video by the time the patient is prepared. So this happens once in a while when we go for a hypermetroid white cataract. We make a small cut, and it can go in a periphery. Even whatever we give a mannitol, we give a glycerol, we make the speculum loose, we give a block, we give a pressure after the block, super pinky and whatnot. But you see that very clear cut agitated flexine, which is named by one eye surgeon of Argentinian, who is just looking like a flag of Argentina. So after luckily I could do the surgery and finished it. But all the time you are not so lucky to finish the surgery in all Argentinian flexines. So patient is getting prepared, so by that time I can show this. So I'm very much proud that I was the first person to introduce trypan blue in whole Asia. We had done this study in '94, and you can see this is a way you can make the puncture. If you make a puncture in posterior capsule during Phaco, why not in an anterior chamber? So this puncture makes three things. It makes the puncture on anterior capsule. When it is getting aspirated, so it aspirates all the fluid, which is a interlenticular fluid, which is responsible to give a more pressure, which is under pressure, and it is controlled very well. So the advantage of this technique compared to other technique is that we can have all the things at a time. No sooner the puncture is made, we suck out the fluid instantly. Diameter is 150, Phaco is hardly 10 or so, and you just wait and suck out the fluid with the same instrument, Phaco probe, and with the forceps we can make. So you can see that the axis is coming on the central part. There is centripetal force. So this very beautifully suggests that the whole, the nucleus is collapsed, the capsule is collapsed. That's the sign. So you can see no sooner is punctured, the fluid has come out, and I kept one case as a live for this if time permits. So this is how you can print the agitated flexines almost in 100 cases, 100% cases. It is done very well. And the irrigation, which is at the mortal height, which is passing over the anterior capsule, gives a positive force over the capsule, so it also helps in suction by the Phaco tip. So outer pressure and inner suction. So this is how the fluid is taken out. And if you like, you can do it again. You can suck after initial puncture also, give a viscoelastic and finish the axis. Now we proceed for the next case. It is, I just scrub and come back.
Sir, have you ever noted any extension of this into periphery while doing this kind of a puncture like this?
Yeah. We can, at least in this technique, I have not seen that it has gone in periphery.
Okay.
Because, in intramuscular white cataract, the whole cataract is full of a fluid, and this fluid is giving a pressure from in to out. So no sooner we make a puncture, the cut is like a balloon, And what we do is, we don't allow time to capsule to get it, get it extended. So puncture and suctions are done together. Say, just a minute. So by this, and second thing is there is a pressure of a fluid of a irrigation that is equivalent to the pressure of the bottle height over the entire capsule. So externally there is a pressure over the capsule and internally there is a suction, and beautifully this is all are done at a time simultaneously. So you don't give a time capsule to go periphery. So that's why it is almost 100% you can get this result.
So is it your preferred technique in all the cases of swollen lens and hypermature?
100%, sir. 100%. As a routine, even my all juniors are doing this thing.
Okay.
And it is, we go to third case. Yeah. So now proceeding for the patient is ready now for the third case, which is a case of a patient who is a male, and we are going to put a techniques IHANS. IHANS, I know financial interest, but IHANS is a choice of IOL in my practice. We have implanted more than nearly 1200 plus IOL, techniques IHANS, and we are very happy with it, results. The patient has a grade 2 to 3, diabetes under control, and reports are normal. Next. This is its, we can say the IOL master. Next. OCT is normal. We take OCT to and all patients. Can go the further first topography. Yes. Okay. Next. I think there is some differences. Yes. Yes. This one. So you can see the astigmatism is more or less regular. There's not a much difference in, but you can see the little bit more on the lower part. Next. In this case, we are going to put a incision. I think this is a different patient. This is not a toric. There is some mix up of the two sheets.
I think this was a previous patient we saw.
I think there's a previous actually. Okay, so you can show here. You can show this. So I show you in my workup printout. So that's why case papers are not detailed. Once you have this workup, we mentioned which OT will be there, where the positions of the surgeon. You can see that we are going to demonstrate here OCCI, that is opposite clear cornea incisions, and there is very complex. We can say a software, whether we are going to put the incision vertical or oblique or same OCCI, yeah. So or temporal. So according to that, the software will tell you are going to put a rectangular incision of a corneal tunnel or a square, and what is the size. And here we have calculated that 2.8 opposite is 2.8, 2.4. So in this case, suppose the patient, we can go for a one diameter of a toric, but the patient is not willing for a toric, so we have chosen this case. Here again you can see the endothelial count is 2769, that is normal. And there are few things we mentioned also, that whether patient is a first one antiviral to be given, whether patient is going to be under block, or patient we are going to keep a blue dye ready or not, patient has been cold previous day, charges are final, and so on. And we write down all the medicines in this printout paper, what is the batch number, what is the expiry of each and every medicines. And right side you can see the investigations are normal, and it is also to be checked at the last moment, including SpO2. So once this printout is there, then patient comes inside the OT. Thank you. So we proceed for a surgery. Must keep her.
I think it is a complete app that way. I mean, it just directs you and tells you also what to do. Inject Viscoat or inject, Orocoat, and then OCCI, everything. It just dictates you to do.
Here patient has a astigmatism of, as I told, the 0.88, and that astigmatism patient is, we can go for a one diopter of a IOL, toric IOL, but this is a demonstration. What we should do, the patient और थोड़ी ओછી कर ત્યાં રાઈટ સાઈડ થોડી ડાઉન નહીં નહીં લાઇટ યસ ઓકે ઓકે ના લાઇટ લાઇટ બસ ધેટ્સ ઓલ સો we can mark this patient, but to save the time we have not marked this, but I'm going to put a incision at 20 degree, which is here, that is the main tunnel, and my right hand, which is again in a circle, I'm sitting on a 20 degree, my table is at 20 degree. Right પર જઈ આંખ હલાવતા નહીં હા yes.
So again, I think that is a very elegant way of making both the incisions. I think we should also start doing it, Rajesh.
Yeah, I completely agree with this method of making the two side ports. It's a wonderful way of doing. So you don't have to hold the conjunctiva, you don't have to do anything. I mean, there can be other ways, but this is a wonderful method of doing it.
A bolus of orocort, and then below that bolus, I put a little bit viscoelastic. So again there is some bubble is there. Better to suck it out for demonstration purpose. Viscose. Sorry, is it on? I don't want a soft eyes. I'm injecting again. You will notice that I'm not making a main incision now. Very helpful in a hypermetropic patients who has a very shallow light. You can see the very well clearly.
Yeah, we can see very clearly.
Says visual on mark. You know, juniors go on asking me that what way we have to do the raxes, clockwise or anti-clockwise. The answer is very simple. If you make a circle, when you are doing any drawing or any circle clockwise, then do clockwise. If you are making the circle anywhere anti-clockwise, so it's a basic control of our hand, we have to use it. So both ways are good, but if you have a habit in clockwise, you can do that. So here there is a roughly, so I'll show you that this is a 2.8 millimeter incision, which is a very good incision so far as fluidics are concerned, and so far as the nullifying the pre-existing astigmatism, and at 20 degree. Second one. Okay, good. So we do the gentle hydro, trying to do in such a way that the fragment of entry capsule comes out. If it is okay, otherwise we can remove by, you see it has come out. Dr. Darjisi had taught me that use 1 cc or maximum 2 cc of a syringe when you do the hydro, so that you have better control and better flow.
So what cc syringe do you use to do hydro?
This is 2 cc, 3
Okay.
cc. Yeah, this is a 3 cc, it is 3 ml. And yes, and never use any syringe for hydro. This is locked so that it doesn't come out or shoot like a bullet. Otherwise, so always use the syringe which has a lock, lever lock, what we can say. If needed, the sister will put additional 1 or 2 drop of Paracan. You see, the two-hand technique for the rotation is very good. There is only a rotation force over the nucleus. There is no stretching of zonules. And as I told you, I do little bit on the reverse side so that the epinucleus is detached from the
This is a
cortex.
kind of wonderful technique. Very nice.
Thank you, sir. In previous case, I was able to see the golden ring. So what I did with the help of a tool chopper, I correct the nucleus with chopper only. Because the patient is a less, endothelial count, and we can save this some Phaco power. But it can be attempted only when the iris is coming out a little bit. थोड़ा height aussi करो थोड़ा. Trying to separate it out. So, the fragments must be separated completely from the mother's brother fragment. Otherwise, there are lots of issues like flower pattern, and you cannot. So I'm just confirming it that it is separated in the center. You can see now. So it's not a very hard cataract. So either we can crack it further like this and absorb one by one. I think it needs a viscoelastic. Patient is. Light માં
Light one? Yeah, okay.
Yes, put a little bit viscose over the surface of iris.
This is under topical or this is under
Yeah, all under topical.
topical. So I think the patient is exerting some amount of pressure, so that is why.
Maybe, and I think for safety purpose, I'm making it a little bit more dilated for safety and demonstration purpose, so that it does not constrict further. It has started constricting. You can see a little bit more dilated than what it was. Vacuum करो.
25.
Height 90 करो.
90.
Okay. So this is again under Venturi pump. The beauty of dual pump is you can do any vacuum of your choice. Just catch with the vacuum. Don't do Phaco here. Make it come to the very comfortable central zone of a safety. So here I am using very less Phaco power. And you can see my tip is always blocked all the time. It is never free.
Yeah.
It is the beauty of a Venturi that you remove more material and less fluid. In peristaltic, you remove more fluid, less material. Because there is some fluid is in and out and creating a vacuum in peristaltic. Just touch and suck and then you can do it. I think ऑफ कर दो. So this is again the same thing. Why I'm putting the second time is I'm confirming that the eyeball is very tight. So I want a stretched and expanded capsule. So once the whole capsular bag is under pressure and stretched, then the stripping of removal of the cortex is very easy. So same thing we do, and I teach my juniors: catch, pull, and then aspirate.
At 90.
100 crore,
100.
highest crore.
Highest.
So if you are not comfortable, you can change the hands. Not necessarily you should do with, you can exchange the hands, and you can exchange the
Polish.
irrigation aspiration. So irrigation is on, and once I fill it with the viscoelastic, then I off. So again I'll put extra visual on, because I want the capsule back stretch when I implant a IOL. So again I'll tell you that I know finance interest, but ICB00, that is iHans, is a beautiful lens which has a unique property of extended depth of focus IOL, and of course it is a excellent material, and it has a little bit add-on power. Exactly I don't know how much, which is not revealed by the company, but some addition of a power is there in an entry surface of IOL, which is very gradual from periphery to center, very smooth transition of a power, giving rise to 1.25 diopter of depth of focus. So at least in my patient, when I keep the target minus 0.3 or so, patient can read at 50 centimeters of distance. That is a computer or reading on notice board or something like that. You see, I always have a counter control with the left hand, and why I used a dialer in left hand? Because if I want to dial, I don't have to ask for dialer to the sister to reposition the IOL. So to have a control and counter pressure or the eyeball, because patient is under topical anesthesia, so you can put this inside. So I don't touch any instrument. With the help of Visilon only. So you could see that here we could use the Visilon as a instrument. So now we are going for a OCCI. So this was a 2.8 incision, and as per the software says, you should put exactly opposite, that is 2.4 incision at 20 degree. So here again, we have done lots of study on this, and we developed the one, we can say the nomogram, and it works. Dr. Sato, who was in Japan, Dr. Sato taught RK to Dr. Fedro. He was saying rather, that it is an internal incision which makes the cornea flatter, not the external. So I don't do a AK, that is arcade keratotomy or so. I do only through and through complete incision. So you put that it is combination of the two things, 2.4 and 2.8, giving rise to nullification of a pre-existing astigmatism of 0.88. Now you can see that I put the lens oblique,
Yes.
that is nasal
Yeah.
up and temporal down.
Hmm.
So there was some study in ASCRS that this gives a minimum chances of negative and positive dysphotopsia.
Okay.
So if restriction of toricity is not there,
Yeah.
if you have freedom to put the lens in any direction, I put it like this, especially this design. So don't forget to hydro the opposite OCCI, because that is also equally important. Now coming to the last step, that is we must remove whatever viscoelastic residue inside the eye, and also viscoelastic behind the IOL. So this 30-second helps in very well in preventing the post-operative high IOP spike. Once we remove this, the chances of blockage by viscoelastic to the trabecular meshes are very less, because you removed almost all. Again, lift up make the speculum loose, lift up both the lids with the other hand, and then inject the irrigation, so that your eyeball is maximally, we can say, filled with the BSS. You can see here, I take a support of upper lid or towel to inject the moxie. So my hand is more stable. I think some air is there, it's all right. So this is the end of the surgery. I should thank my patient
Nice.
also.
Yeah.
But no, I think
Very nice demonstration, and you described each and every step very nicely, sir.
Oh, thank you, thank you, sir.
Clearly, and I mean the concept was absolutely clear, and it was a very good teaching kind of a video, sir.
Yeah, thank you very much, sir.